Hi everyone. Welcome to the ICS webinar today on nutrition in the ICU and ICU associated weaknesses. And we are trying to put everything together in this 1.5, 2 hours. And I would request all the participants to also put in their questions so that we can have a very fruitful discussion. We've chalked out a very nice plan today, and I thank ICS for having us over. I thank Dr. Rakesh Chawla and Dr. Amita Nene, my very dear friend from the ICS to keep making this happen every week. And I also thank Aditya from Zorbia for making it possible today. I have a very, very good panelist and a speaker here, and I'm sure we are going to have fun trying to access and discuss each and every session on section on whatever nutrition needs to be discussed in the ICU, especially for pulmonary care patients. Without much ado, I will just introduce the topic and then Dr. Alisha. First, I will just introduce what we need to be doing for nutrition and acute syndrome. I just want to put my slides up. One second. Yeah. So welcome again to this webinar. And we have been reading a lot in the news about the final day of the hunger strike of 20 days. And my question here is how many of us think we can keep our critically ill patients who are pulmonary in origin without feeding and for how long? And I don't think all are like our martyr Sonam Wangchuk, but ICU patients are totally different. They are not healthy before they come in, and they don't have much of nutritional capabilities during the ICU stay. So I think it's very important for us to understand that ICU acquired weakness can happen at any time in a patient's ICU stay. And the critically ill patients, because of catabolism, protein breakdown, and many other factors, this can happen. And there is a loss of muscle mass almost 850 grams per day. And this starts from day 3 to 5 in the ICU. About the ICU acquired weaknesses, at least 1 in 4 patients develop it, and it increases the duration of mechanical ventilation, physical function, long term is hampered, quality of life is hampered, mortality is increased, and the cost also. So the fuss about nutrition, and many a times we feel nutrition is not adequate, but this cartoon actually tells you a lot. We are looking at the body mass index. We are looking at 3 pulmonologists and intensivists looking at the patient and the nutritionists and the works. We are also keeping a tab on the glucose here. So it's important that a healthy outside starts from a inside of the patient. And we know that every kg can be lost per day, a lean body mass in a critically ill patient, and that can be extremely dangerous. So without much ado, let's deep dive into the precision nutrition. And I call upon Dr. Alisha, and it will be a pleasure to introduce Dr. Alisha before she starts off with her entire presentation on nutrition and ICU associated weakness. So can I have Anisha's slides? I will just stop sharing.
I'm sharing it.
Yes. Yeah. So Dr. Alisha is again a very close friend of mine, Alisha Chaudhury. She's done her MD Pulmonology, IDCCM through the critical care, EDIC also, and she is FSM. She is a consultant in the Department of Critical Care and Pulmonary Care at the Sum Hospital, Bhubaneswar, and we've done a couple of workshops together. She has a lot of awards and achievements. She's on the editorial board of the Critical Care Communications 2025 to 26. She's an EC member, ISCCM Bhubaneswar branch for 2 years, fellowship in sepsis, severe infections, stewardship pathway, and she's always involved in major issues dealing with critical care and pulmonary care. She is in the ICS. She has the IWLH travel grant in 2019. Best paper was awarded in NAPCON and the state conferences. 36 publications in national and international journals and multiple chapters in books. And she has interest in mechanical ventilation, POCUS, ID, and toxicology, and I'm sure much more, and definitely in nutrition. So over to you, Dr. Alisha, for a amazing presentation, and then we will try to answer a lot of questions and have a good panel discussion with my esteemed panel here. Over to you, Dr. Alisha.
Sir, are my slides visible, sir?
Yes, absolutely. You are ready to go.
Thank you very much, Khusrav sir and Amita ma'am and Rakesh sir. It's always a pleasure to be in these ICS webinars and for the kind words of introduction, both of you, and for all the motivation. So with the topic which has been given to me, nutrition in critically ill, all that you need to know for the next 15 to 20 minutes, I really hope I don't put you to sleep. I can, sense the enthusiasm in the audience. A very classic Bollywood movie from quite a long time and one of my favorites. It also mentions the first thing in the movie title, it's roti. That actually shows that I think in all spheres of life, food is really important. So why not for the ICU patients? And this is not something, a very new concept. This concept has been there from quite a long time. It's almost 100 years earlier. An Irish physician felt that feeding patients when they are very sick actually made them do better. So this has been a concept which has evolved. We are slowly realizing it, and we are accepting the importance of nutritional therapy in critically ill patients. When you see a patient in the ICU, your question will be, should I feed this patient or how am I going to feed this patient? I think how am I going to feed this patient should be the doubt, not should I feed this patient, because you have to ensure every patient in your ICU gets nutrition as per their requirements. Now, in my ICU, when we round, whether it's our residents or our nursing staff, I always tell them to follow a flow chart so that first they should know, why do I need to feed the patient? Which patient should receive feeding? What is the route preferred through which you should feed a particular patient? When should you start your feeds? What is the feed composition? What type food you are giving? Like how you decide today, I want to order some burger or pizza. Similarly, for the patient, what kind of food you want to give? How much feed is to be given, the volume of the feed. And then once you give a therapy, even something like nutrition, you need to see whether your patient is tolerating it or not, any complications the patient is developing. So all these things you should need to keep in mind. And these questions should always be answered in your rounds while you are seeing these patients in ICU. Now, long back, almost in 2013, Puducherry et al. Came up this very interesting paper in JAMA, and what they saw was when they looked at this rectus femoris muscle in critically ill patients, you can see the graph on the right side, around 10 days of admission in the ICU, the muscle mass actually decreased nearly 20%. And it was even worse when it was in patients when these patients were associated with multiple organ failure. So look at the significant amount of muscle loss. And we all know the ICU patients are in acute stress, a very strong catabolic phase. Sometimes these patients are not well fed at home, prolonged bedridden patients, so there may be pre-existing malnutrition, around 40%, altered metabolic pathways because of very different physiologies undergoing in the body, and a very mixed ICU population. You have a burns patient, you can have a trauma patient, you have pulmonary patients, so very different kind of population in the ICU. Why am I worried about nutrition is because nutrition, as we know, will maintain gut perfusion. When you give food, it stimulates your gut. So more blood supply. That's why you feel sleepy in the afternoon, right? So that way, so what we are trying to emphasize here, that nutrition is maintaining your gut perfusion and maintains the homeostasis. Your lymphoid tissue, gut lymphoid tissue is maintained, so immune function is maintained. Your gut microbiota with all the probiotics which you're eating in your diet, that also helps. And finally, you have to understand that it also maintains the autophagy. At some point of time, your body will want to remove the cells which are not good, like destroying your own cells. But it's a healthy process of doing it. And that happens to the activation of the mTOR pathway. Some of it is actually extrapolated to what intermittent fasting you do. You don't overfeed yourself. You eat the right amount and you give a gap so that your body, works, tries to digest and work on your underlying fat stores and also maintain the autophagy. Now, if my patient is malnourished, what I'm really worried about? So morbidity, wound healing, infections can occur because immunity is reduced, like what we just read, other complications, and that leads to mortality, treatment, and increased length of stay in the hospital. So finally, what am I looking at? One is the cost factor, because ICU stays can be really costly. And what is the quality of life after that, a patient who has gone through so much? So this is a very classic graph which shows the arc of nutritional status. Why do we need to know? It's not like any patient who walks in the ICU, we just start feeding the patient. You need to know what kind of, what phase the patient is actually in. So there are two trajectories. There is one anabolism where the tissue building happens, the catabolism where the tissue breakdown happens. So when patients enter the ICU, the critical care unit, they're mostly in the catabolism state. And the initial, if you look at the day 1 to 2, that is the acute phase, the early period, heights of catabolism, lot of tissue breakdown and muscle breakdown is happening. Then slowly the catabolism is still there, but obviously the intensity has come down. That is day 3 to 7, the acute phase, the late period. And finally day 8+, which is marked more by like a recovery or a rehabilitation phase. So what you see from acute injury, we go up to the rehabilitation and recovery, the anabolic phase. But certain patients can be in this prolonged inflammatory and catabolic syndrome. They are just not improving. There's ongoing muscle wasting, sarcopenia, immunosuppression. These patients are ventilator dependent, recurrent infections. They're not improving, and poor functional recovery. So we need to know where our patient stands while feeding, a patient in ICU. We need to know where does our patient actually stand in this whole trajectory. My next question would be, which patient should be fed in the ICU? You cannot just random give orders, okay, start feeding this patient. That's not how we work. We need to know which patients need to be fed. So for that, I need to know how is my patient malnourished? If my patient is malnourished, it is mild, moderate, or severe, because my goals of nutrition, my diet will vary according to that. So how do we do that? Nutritional assessment can be clinical. Just looking at the patient, sometimes you see a frail, elderly, cachexic tells you that, okay, fair idea. Okay, this patient looks malnourished. Anthropometric measurements, mid-arm circumferences, muscle thickness are one way of doing it. Biochemical like albumin levels, pre-albumin levels, though we can use albumin as a surrogate marker for the malnourished state of the patient, but it's not very definitive. I think the most emerging modality to look at this malnourishment assessment is assessing the lean body mass through imaging. Focus, yes, focus has got a very important role nowadays, especially looking at the quadriceps and rectus femoris muscle thickness and the diameter of the muscle. There are different scores. So what scores we commonly know? One is the subjective global assessment of the nutritional status, very comprehensive score. Most of the ICUs have it. Something which has newly come up is the MUST score, whether there are 3 steps. You're looking at the BMI score, weight loss score, and acute disease. And then you classify the patient as low risk, medium risk, or high risk of malnutrition. The other scores which we know are the NRS score, nutritional risk screening score. But the most important one, which even I use in my ICU, is the Nutrix score. It looks at 5 important variables: age, Apache 2, SOFA, number of comorbidities, days from hospital to ICU admission. And if you have interleukin levels, I mean, if it is accessible for it, I mean, to get IL-6 levels for your patients in the ICU, if you could add that, then that score becomes as M-Nutric, which is modified Nutric score. So anything more than 5 tells you that this patient is at high risk of malnutrition, and that needs to be addressed immediately. There are upcoming scores like GLIM scores which have come up, which after an initial screening with Nutric or NRS, you then go and assess the grade of malnutrition. My next doubt will be, which route should I, through which route should I, give nutrition to my patient in ICU? We have nasogastric, gastrostomy tube, jejunostomy tube, nasoduodenal or nasojejunal, and then you have intravenous alimentation, that is through the peripheral parenteral nutrition or the total parenteral nutrition. But having said that, we just now read that giving a nutrition, how it maintains an intestinal homeostasis, intestinal gut microbiota. So anything physiological is always good in life. So that's why enteral nutrition is always preferred, until and unless there are clear-cut contraindications. There's bowel ischemia, or there are some obstruction where you think you cannot feed the patient, then you think of other options like parenteral or the other NJ tube or a nasoduodenal tube. And a combination of enteral and parenteral nutrition also is not very routinely recommended. So if possible, enteral nutrition is the ideal because it is most physiological. Now, when should actually feeding start in the ICU? As early as possible. Just think somebody is not well fed, hungry, I mean, almost empty stomach from past 24 to 48 hours. So as early as possible, because you are going to give that calories, that extra proteins, which will help him in his recovery, muscle mass, and all the catabolism which is happening to counteract that. So as early as possible, and tube feeding at least to meet initial 50 to 60% of your nutrition targets of the patient. But the next question will be, which most people ask, you want us to start feeding, but what about somebody who's hemodynamically unstable? Yes, it's definitely a concern, because somebody whose blood pressure is very low, the gut won't be getting perfused properly. So yes, there is a risk of nil absorption through the gut. So there are a lot of chances of abdominal distension and vomiting. So I need to be careful. But having said that, if you have resuscitated your patient well and your vasopressors have stabilized, even though you can't start at the target feeding rates what we want, you can start at low flow rates. Low flow rates is something what we call as trophic feeding. Start at very less rate, something like 10 to 12 kilocalories or something per hour, and then it comes up to around 500 kilocalories per day, very low, and you monitor how the gut is behaving to that trophic feeding which you are providing. And once the patient is stable, like I said, you start within 24 to 48 hours. Gut function monitoring is important. But what if now I say that initially the patient had stabilized, now this patient has gone up to 0.4 to 0.5 mics of NORAD, you have added vasopressin. Even in that case, we can still consider trophic feeding, but you need to constantly monitor the gut function and how the patient is tolerating it. But on very high vasopressors, triple vasopressors, very high, and you are seeing the lactates are high, your abdomen looks distended, your patient doesn't look good, toxic. In those cases, maybe we can wait for some time. There is no harm in waiting 24 hours. And once you see the vasopressors are tapering down, your vitals are stabilizing, you can think of starting. So yes, very high vasopressor support, it is difficult. But if you ask me exact deadlines that, okay, at which what particular stage do you want us to start? It's variable. Even on dual vasopressors, I would consider giving trophic feeds to my patient, but I will keep monitoring. On triple vasopressors, I might be a slightly little cautious and be very careful. Now, what kind of feeds actually should be started in the ICU? Now, it depends hospital to hospital. So you have scientific formulas, you have the blenderized feeds, which is nothing but your kitchen feeds. We think scientific formula feeds are better than blenderized feeds, because in a way that because these kitchen feeds, there is always a high risk of high microbial contamination. There can be inconsistency in the amount and supply of nutrients, whereas your scientific formula feed would have clearly mentioned that this is the amount of carbohydrate, this is the amount of protein or fats. But in kitchen, you are always not sure is the ratio or the amount of the nutrients is correct or not. There can be higher osmolality and viscosity of the kitchen feeds. And if not blended well, these kitchen feeds can actually block your feeding tube. But having said that, in a resource limited setting, I can't expect the patient to get a scientific formula feed. So yes, kitchen feeds can still be given, but all these parameters what we discussed as limitations of kitchen feed should be kept in mind. Prefer closed system ready to hang formula feeds, and what we use is actually a standard polymeric formula in the ICU to start with. Now, what do I mean by a polymeric formula? So look at these three types of feeds: elemental, semi-elemental, polymeric. Let's go from the bottom. Now, polymeric, you look, the protein is a whole protein, polysaccharide carbohydrates, and then long chain triglycerides with some amount of fiber. When you're going to semi-elemental and elemental, you see a more breakdown form of protein, a simpler form of protein, which is peptides, free amino acids. The polysaccharides are now oligosaccharides, glucose or oligosaccharides. The long chain triglycerides are medium chain triglycerides, and no amount of fiber. That itself gives us an idea. Now, if I'm feeding my patient through the Ryle's tube or the nasogastric tube, polymeric feeds is good to go. But what if I'm feeding my patient through the nasojejunal or the nasoduodenal? I cannot give the polymeric feed because you are already bypassing the stomach and the duodenum over there. So over there, the feed has to be simple, because that is the way your food goes down from your esophagus, breaks down, goes to the stomach, and then breaks down and goes to duodenum, small intestine. So that is why the semi-elemental, elemental, they have more of a role in case of especially acute pancreatitis patients who don't tolerate nasogastric feeds. In those cases, we prefer giving nasojejunal feeds that will be elemental or semi-elemental form. Now, there are a lot of specialty disease-specific formula, like for pulmonary patients, they may say there's a high risk of carbon dioxide production, so give a low carbohydrate and high fat, but it's not routinely recommended. The goals are different. Micronutrients, sort of immune modulating enteral formulations, glutamine, arginine, and then selenium, zinc, and different vitamins. Again, not routinely recommended. We will definitely consider them in special situations. So that I will be mentioning later. Now, how much feed is to be given? So, as in a particular feed, I would want 50 to 60% of the carbohydrates, then the lipids, 15 to 20% of the proteins. What is the thing what I'm mentioning, showing the figure on the right side is the indirect calorimetry. Now, to know what amount of energy I'm giving, I will need indirect calorimetry. The basic concept is we need to calculate the resting energy expenditure, which is the basic amount of energy we want to perform our, basic functions, daily functions in a resting state. Okay. So that is difficult to calculate on a regular basis in the ICU. You will have a lot of equations like Harris-Benedict and Toronto formulas and all. But the ideal way is to do a indirect calorimetry, which in a ventilator or a spontaneously breathing patient, we look at the oxygen consumption and the carbon dioxide production. And based on the equation, we calculate the respiratory quotient. And that gives you an idea that if the respiratory quotient is somewhat around 1, so this patient has more of, carbohydrate consumption. So you give more of carbohydrates. If it is 0.8, it is like a mixed carbohydrate and fat. So accordingly, you give a mixed diet. And anything less than 0.7, more of fat consumption. So you give fat. But sadly, what the reality is that indirect calorimetry is less than present in very less ICUs. I think less than 5% of ICUs all over India. I don't know if in Indian ICUs have it also, even in other Western countries. So in that case, what do we prefer? We assume that the resting energy expenditure calorie target, at least we keep it as 25 to 30 kilocalorie per kg body weight per day. That is our goal kilocalories, which we should be giving the patient. In that, I want the carbohydrate and fat levels to be in a ratio of 60 to 40. It can be made 50-50 depending on the patient's requirement, and that is how we individualize it. And then there's something protein requirement, which is around 1.2 to 2 gram per kg body weight per day. Now, once we know this 25 to 30 kilocalories, the protein requirement we know, there is something called as non-protein energy. The non-protein energy will be the calories we are getting from the carbohydrate and the calories from fat. So when I speak, a patient is getting 1600 kilocalories, I am saying that the patient is getting calories from his protein, also calories from the carbohydrates and fat, and that is how the proper nutrition prescription will be. So ideal measurement, as I mentioned, but most commonly we use Harris-Benedict in ICU, and sometimes we just assume it is 25 kilocalorie and we start feeding. So again to the arc which we came of the nutritional status. So in the day 1 and 2 acute phase, we know we want to start early nutrition. We don't want too much of overfeeding. Protein has to be given because muscle mass, healing, and don't aggressively push calories in this phase, but target 25 to 50% of your resting energy expenditure. When you go to day 3 to 7, the catabolic phase inflammation has started to settle, but muscle breakdown is still continuing. So now our target has to increase from 50 to 70% of estimated energy targets. So gradually, start increasing your calories and protein. And then lastly, the recovery and rehabilitation phase where inflammation is resolved, the patient is anabolic. So target 100% of your resting energy expenditure. Here you focus on adequate calories, high protein, physiotherapy, and rehabilitation. What is this over and under feeding I'm constantly speaking about? If you underfeed, obviously you are not giving enough calories and protein. There's loss of muscle mass, fat mass, immunity is impaired, as I already discussed, healing process is impaired, new infections and hypoglycemia. But if I overfeed too much of calories, again hyperglycemia, impaired immunity, lot of carbon dioxide production, and lot of overfeeding volume, also the cumulative balance increases. So weaning failure, hypercapnia, difficulty in weaning these patients, liver steatosis and fat mass. So we need to balance that we are not overfeeding the patient. Underfeeding in the initial acute phase, what we discussed, is still acceptable. If we advance in the next phases to come, if we advance and achieve the targeted calories, but overfeeding is never acceptable. So, for example, if I say 1600 kilocalorie, your nutritionist has written in the ICU, patient is getting 1600 kilocalorie per day, 100 gram protein per day. First thing is, we know protein is 100 gram. Protein gives 4 kilocalorie per gram. So protein itself is 400 kilocalories. That tells us that your non-protein energy is actually 1600 minus 400, which is your 1200 kilocalorie. So that is how your prescription should show. And then when you know the 60-40 ratio of the carbohydrate, your carbohydrate comes up to 180 and your, 720 kilocalories, and your fat calories come up to around roughly 480 kilocalories. So the nutrition prescription should tell what is the total calories, what is the protein calorie, grams for protein and calorie, and the carbohydrate and NPE, that is the carbohydrate and fat calories, should also be mentioned. That is a complete nutrition prescription. Now, like I mentioned, once you have given enteral nutrition, my next thing would be how do I monitor it? So avoid inappropriate cessation of enteral nutrition and minimize nil per oral statuses. Gastric residual volume, despite very strict guidelines, people still continue to do it. Understand that ICU patient cannot absorb a feed like you absorbed, because there are a lot of there are a lot of like sepsis, critically ill case, so delayed gastric emptying. So if after 2 feeds before giving another feed you withdraw, you might see 200 ml and you're worried. But if there are no signs of gastric intolerance, we can wait. What are those signs? Abdominal distension, absence or abnormal bowel sounds, decreased passage of stool and flatus, vomiting, bowel dilation, and diarrhea. So holding EN actually for GRVs less than 500 ml should be avoided. Rather, what you can do, you can reduce the volume, give continuous feeds, add prokinetic agents. Yes, if there is abdominal distension, patient is not flashing flatus, multiple episodes of vomiting, you need to hold. Now, what if the patient develops diarrhea? Don't stop there. Make sure you rule out you're not giving a hyperosmolar feed, rule out C. diff infection, use a soluble fiber containing formula. Routine use of probiotics is not recommended. We read a lot about enteral. Now, what about this parenteral? You're going in a different way, different route, so it's parenteral. In a case of low nutrition risk, you can still wait for parenteral nutrition over the first 7 days. How do you know it's low nutrition risk? With your Nutrix score. High nutrition risk or severely malnourished, you need to start PN because you're not able to give enteral nutrition at all. But in cases of patients when you have started enteral nutrition, it's 3 to 4 days and you are still not able to go more than 60% of the energy requirements, parenteral nutrition may be started. So low nutrition, wait. Not able to reach target after 4 days can give parenteral nutrition. High nutrition, not at all feasible to give enteral nutrition because of bowel pathologies, start parenteral nutrition. And what you should be careful about, that when you are feeding this patient, they may be very malnourished, they can end up in complications like refeeding syndrome. So electrolyte monitoring, be very careful about the central lines, a dedicated port for parenteral nutrition. Hyperglycemia, this can lead to glycemic control, and duration of parenteral nutrition, and as early as possible transition to early enteral nutrition is feasible. A little bit about the refeeding syndrome, which is very important. It's under-recognized and can be very fatal. Sudden excess delivery of calories. There will be once you give a lot of calories, there will be a surge in insulin because of the glucose in the body, and insulin will drive all the glucose into the cells, and glucose will take away phosphate, potassium, and magnesium, and that leads to the hallmark biochemical feature, hyperphosphatemia. You see, suddenly once you feed these patients, they go into cardiac failure, and they worsen. So we need to be very careful, especially patients with it leads to increased length of stay, weaning failure, and poorer outcomes. So these would be the high-risk patients like alcoholics, patients with substance abuse or low BMI, bariatric surgery cases. So you start slowly, advance to the patient needs, and add thiamine to avoid this situation. Coming to special situations, we see a lot of obese patients in our practice in pulmonary critical care. The goal is to give them high protein and hypocaloric feeding. High protein because we know it's a critically ill state. We need high protein diet to preserve the muscle body mass and help in the healing and tackling the infections. Hypocaloric because they already have good fat stores. So when you give hypocaloric, you're actually utilizing the fat stores in the body. So if you're going by the ideal body weight, yes, 20 to 25 kilocalorie. But if you're going by the actual body weight, it is 11 to 14 kilocalorie. The protein intake is roughly around 2 gram per kg ideal body weight for the different BMI, and even up to 2.5 in higher BMIs. Sepsis, as we discussed, patient on stable vasopressors, or you can start trophic feeding, escalating vasopressors, not tolerating weight, and protein will be around 1.3 to 1.5. We can go up to no role of immunonutrients and micronutrients. Liver failure, which we can see associated with our pulmonary patients sometime, enteral nutrition is preferred. No protein restriction is recommended. No special beneficial effects of branch chain amino acids. When you go to renal failure, Standard enteral nutrition formula, just be a little careful about your electrolyte imbalance. You should go for low potassium and low phosphate formulas. Somebody on hemodialysis or CRT, especially CRT, you need to hike up your proteins almost to 2.5 gram per kg per day. And then coming to the most important, our lung, we go for calorie dense EN formulations. The reason being you don't want fluid overload. There may be a role of, giving a little high fat, low carbohydrate formulation, but not as a regular basis. You can try this if you have indirect colorimetry. Otherwise, the best thing is just avoid overfeeding. Monitor serum phosphate, especially vitamin D levels, serum phosphate, magnesium levels need to be monitored, especially in lung patients, and replace when needed. Special situations, what we see, I mean, patients, people who are especially into critical care, pancreatitis, TBI, and burns. Pancreatitis, as I mentioned, semi-elemental formula, but TBI and burns are that special subset of patients where I said that immunonutrition and, arginine, selenium, micronutrients have a role. So this is in brief like a ICU nutrition protocol based on all the guidelines we have. Once the patient is admitted, how do you screen? How do you assess the risk of malnutrition? How do you grade them? And then you decide whether you want to start oral or you want to start parenteral nutrition. Can you wait? Check for tolerance. Do you think the patient is adequate fed, or do you want to add on a PN if your goals are not met? Now, some myths and facts, pre-pyloric versus post-pyloric feeding, there's no significant difference. Both intermittent and continuous are appropriate. Continuous, the only thing is that it is more nursing friendly. Intermittent is good enough, especially if there are glucose level issues and all. That way is intermittent is better. Abdominal surgeries, there is nothing like in open abdomen you cannot start feeding. You can start feeding the patient, but make sure bowel integrity is fine. There is no bowel ischemia. Bowel continuity is maintained, and your vitals and your lactates are all in place. Intestinal anastomosis is also not contraindicated. NBM for extubation, please don't do that. Routine measurement of GRV, again not required, because understand the physiology. Even if you have prone and paralyzed the patient, still continue enteral nutrition safely. Nothing is going to happen. So my take-home things will be: feed early when safe, use the enteral route if GI tract is functional, it's physiological. Weight-based equations are preferred for energy protein. If you have indirect calorimetry, then nothing like it. Look for signs of gastric intolerance. Tailor nutrition. Look at the underlying risk factors: obesity, AKI, malnutrition, refeeding risk. Multidisciplinary team approach is the way to go for nutrition, dietitians, pharmacists, and nursing. And understand that nutrition is not supportive. It is therapeutic like any other drug in the ICU. So these are the different guidelines we follow when we, read about nutrition. Thank you very much.
Thank you, Dr. Alisha. This was an amazing presentation and one of the most precise nutrition talks that I have heard. And I wish we can do such precise nutrition guidelines also and prescription in our day-to-day practice. The amazing lecture, and you've answered quite a lot of queries, but I have a galaxy of friends and panelists who are here today. And we will hear from them as to what we should be doing in the prescription format and whether that prescription is actually getting delivered to the patient. And before that, I want to share a good news that we've got 1988 logins, nearly 2000, and that's a huge number. And thanks to the amazing panelists that we have today and Alisha as the speaker. A journey of a patient in the ICU is very dynamic. You cannot really differentiate an acute phase from a recovery phase, etc. And you need to understand that there is lots of inflammation, catabolism, inflammatory changes happening. And therefore, the prescription cannot be written on day 0 or day 1 and continued as a prescription, same prescription throughout the journey of the patient. So we need to understand that what we prescribe should be got to the patient. And as Alisha mentioned, we need a full team spirit for that, team effort for that. So let's hear the nuances of nutritional therapy in our ICU practice from our esteemed panelists. And it is a pleasure to introduce them all to you. So can I start with... This is in no order of seniority. Yeah, this is Dr. Neel Thakkar. He's worked with us at Hinduja. He's a great speaker and a very good pulmonologist. He comes from Barodara. and he's done DNB, EDARM from Paris, DTCD, IDCCM at Hinduja, where we work together. And he's got so many degrees of FICS, FLAB, etc. He holds a current position of consultant pulmonary critical care at the Zydus Hospital, Baroda, Gujarat, which is probably the biggest hospital in that area. He has 40 international and national publications, presentations, and about 5 international and 5 national chapters in ERJ, chest, and other very good textbooks. He has lots of memberships, the European Diploma in Adult Respiratory Medicine from Paris, elected governing body member, Indian Chest Society, and he is very active in the same ICS algorithm. Executive Committee member, Society of Respiratory Medicine, Baroda, Chest Group, and an executive committee member in the Indian Society Critical Care Medicine. He is also a member, as mentioned earlier, of multiple societies. And here are the awards that he is bestowed with. He is felicitated with the Chief Minister of Gujarat, Gujarat Beyond Growth Awards in Feb 2026 at Ahmedabad for excellence in pulmonary critical care medicine and community health initiatives. It's very important to reach out to the community as well. Times of India Award for Excellence in Pulmonary and Critical Care Medicine in April 2025. Certificate of Commitment awarded by World Book Records, London, for work done in the COVID-19 pandemic in March 2022, felicitated again by the Chief Minister of Gujarat. Chest Foundation Grant Award 2019 for presentation of at Chest 2019 in New Orleans, organized by the ACCP, and the ICS Grant Award for Best Research for Presentation at ERS in 2018 in Paris, organized by the ERS. I'm going to ask for at least a half an hour more because we have such an illustrious kind of panelists here. So welcome, Dr. Neel. Now it's a pleasure to introduce Dr. Aneesa Shahul, and she's a DM, MD, DM from AIMS Jodhpur, MD from JIPMER, MRCP UK, MRCP, SCE, and DNB, EDARM, and MNAMS. Her professional highlights are she has top 20 young pulmonologists of India. She has been awarded by the ACCP. That's wonderful. Organizing member of the national conferences, publications in PubMed index journals, including Journal on Bronchology, and her interest is ILD, airway disease, critical care, interventional pulmonology, pulmonary infections. Next. Abhishek Tandon, again, a very, very close friend of mine, and we've had a few conferences together also. He's MD, DM, FAGE, and FIAB, Consultant, Department of Respiratory and Sleep Medicine, Medanta, Lucknow. That's a wonderful hospital there too. Recognized faculty for the following postgraduate and fellowship programs: a fellowship in interventional pulmonology, DNB respiratory and sleep medicine, IDCCM, fellowship in sleep medicine, and his areas of interest is asthma, sleep disorders, interventional pulmonology, and ARDS. And he has about, again, 35 publications and 7 book chapters. And he's been awarded with gold medal MD at the PD Sharma PGIMS Rohtak in 2020. He's also got a DM in gold medal in DM AIMS Jodhpur. I got 2 gold medalists, medals. That's great, Dr. Abhishek. I didn't know about this acumen before. And he's been the president's, he's got the President's Appreciation Award, IMA Lucknow, and the ERS ICS Travel Grant in 2024. We now move on to Dr. Hariprasad, who's a very quiet but a very intelligent pulmonologist. He's MD DM in pulmonary critical care and PGI from PGI Chandigarh. He's a consultant pulmonary and critical care, Apollo Hospitals, Bangalore. Interventional pulmonology, ILD, asthma, and allergy disorders are his areas of interest. And he has 25 plus publications and book chapters in index journals and 322 citations. That's a huge amount, Dr. Hariprasad. Welcome to our group. And last but we have Dr. Aneesa. Yeah, have I introduced everybody? Okay, yeah.
So I'll introduce Khusrav sir then. It's a pleasure to have him as our moderator over here. for all the ICS ICU webinar series. Sir is HOD Emergency Medicine and Critical Care Consultant from PD Hinduja National Hospital in MRC. The major achievements list is quite big because of all the glorious years in critical care he has given. Gold medalist and in the first certificate course held by ISSM in 1999. First to bring the AHA, BLS and ACLS courses to India in 2000. A recipient of Lifetime Achievement Award in Emergency Medicine in 2015, and also the FICCM from the ISSM Society, co-authors of textbooks in emergency and trauma care and signs and symptoms in clinical practice, recipient of the Times Healthcare Awards as Legend in Critical Care and Emergency Care in 2018. He was the inspiring ID intensivist in India 2022 and the core member of the Maharashtra Task Force for COVID, and the most iconic healthcare leadership award in critical care and internal medicine by Dynergic and Golden Aim recently in 2026. We are very lucky to have you here, sir.
Thank you. Reading everyone else's introduction was amazing, and I feel the most inferior to all of y'all. And I'm so proud that we are moving forward. And I'm just looking at constantly the messages, and we are at 1988. I'm sure we'll cross 2000 logins, and let's make it worth with a good discussion. And I'll request all the panelists to keep their answers brief because we've already covered this. And then we will take the questions in the chat box, and we will try to address every single question on nutrition in the ICU with emphasis on ICU associated weakness. So the first question to Neel, how do you prescribe nutrition in the ICU for a critically ill patient? So let's start basic. And how many calories do lipids, proteins, and carbohydrates actually give?
Thank you for the kind introduction and being a very amazing moderator, sir. I've learned with Dr. Khusrav, sir, and sir, like with the topic also, and even in all medical emergencies as well as critical care, he makes sure that all patients are evaluated and treated in detail. Thank you, sir. Sir, so coming to the question again, when we prescribe for any critically ill patient, I think Madam has discussed in detail regarding. So the two questions that we need to ask whenever we are dealing with a critically ill patient, one is how urgent is it to aggressively give nutrition to the patient? So Madam has already discussed with us regarding the Nutrix score as well as the subjective global assessment. In our ICU, we used both, but the predominant, the one on the ICU charts is still the subjective global assessment score, which our dietitian uses in concordance with the ICU protocols here. So in that, we have various parameters, including the medical history, the weight change, the dietary intake, the GI symptoms of the patient. If any comorbid illnesses are there, is there any recent weight loss?
Neel, I'm sorry, the scoring system we'll check with later.
So if we look at the target, so
calories, proteins, the target, yeah.
So if we look at the calories, if for example, if there's a patient with 60 kg weight, then we make sure that at least in the initial phase, we target to around 25 to 30 kilocalorie per kg per day. So we try to reach to around 1800 kilocalories for around a 60 to 70 kg patient. For the proteins, the ideal target we try to reach is around 1.3 to 1.5 gram per kg per day. So roughly for a 60, 70 kg patient, we'll reach to around 80 to 90 gram of protein per day. And whenever we decide on the protein and calories, we also, suppose we look at the other macronutrients, then the fat has to be around 30% of the total calorie requirement. So if a patient has, say, around 1800 requirement of the total calories, then the fat requirement will be around 600 kilocalories. So roughly 30%. So accordingly, we calculate around 60 gram of fat for a particular prescription. If a patient has a Ryle's tube feeding, so if 200 ml feeding is going on 9 times, we have to make sure we discuss with our dietitian and plan that the rough calorie requirement will be around 1800 kilocalories, protein around 80 to 90 gram of protein per day. And again, fat and carbohydrate we calculate based on the patient's requirement and plan accordingly. So, and like I said, it is important, most important parameter is the protein and the kilocalories, but carbohydrate, fat. So even based on the calories per gram. So roughly the carbohydrate, protein and the fat. So carbohydrate and protein roughly 4 kilocalorie per gram we target. The fat around 9 kilocalories per gram. So roughly accordingly we try to differentiate. So this is just a rough parameter, but based on the individual condition and the need of the patient, as well as like I said, the risk of the patient, nutritional risk, and the route again, enteral will be preferred in such cases. And I think rest has been discussed in our session. Yes.
Very nicely said, Neil. So we are giving everybody 25 to 30 calories. Maybe we can start with trophic feeds and then we'll give them proteins. And when we say calories, we usually look at non-protein calories. So proteins, we do not count as that. And as you mentioned, you can either give them as intermittent feeds or you may have a pump, a feeding pump, and give a continuous infusion of the feeds as well, just like you may give a continuous infusion of drugs. So the next question is to Aneesa. Dr. Aneesa, what is the need for prescribing nutrition in the ICU? And why do we need nutrition? Is it very important, or we should focus only on the ventilator and the vasopressors and the urine output? So how important is giving nutrition? Just because of eating, or does it have some role? Yes.
Thank you for your kind words of introduction, sir. So coming to your question straight, when we put a patient in ICU, our first and important target is to bring him out of the ICU. So for that, we have to prevent the muscle wasting. We have to protect him from getting any secondary infections. We have to promote wound healing, especially if we have patients of burns or trauma, post-surgery, or even those who have some certain pressure ulcers. So it will also providing the adequate nutrition will promote wound healing, and also an early enteral nutrition can preserve the gut integrity and thereby prevent any such cross infection due to bacterial translocation. And especially if we are putting any patient on ventilator, we have to preserve their diaphragmatic and respiratory muscle function. So that's the importance of adding correct amount of proteins, fats, and carbohydrates in the diet. Overall, with the correct nutrition, we can shorten the duration of mechanical ventilation, length of ICU stay, decrease the rates of cross infections, and overall the patient recovery and quality of life after discharge is very much determined by the nutrition which is provided.
Yeah, thanks, Dr. Aneesa. So there are multiple reasons why we must be feeding the patient early. And we also need to know that the gut is the motor of sepsis. So if you leave the gut alone and don't feed, then there will be enterocytes will not be maintained. The gut integrity won't be maintained, and it will be there will be bacterial translocation, and it will propagate sepsis. So that is one major reason why we should be using the gut and we should be starting nutrition. Well said. Abhishek, when is the appropriate time to start an enteral nutrition? Within 2 days, 3 to 5 days, you can wait up to 5 days, or it doesn't matter when you start?
So before answering this question, I'll just take a very quick moment to thank Amita ma'am for making me a part of this webinar, and to you, sir, for this kind introduction. It's always a pleasure whenever you are there around. So I'll be very quick and brief. So to answer your question, the answer according to me would be within 2 days. I would generally avoid or delay enteral nutrition only in conditions with an uncontrolled shock, bowel ischemia, intestinal obstruction, or an uncontrolled GI bleeding. And even in patients who are receiving vasopressors, unless and until the vasopressor requirement is increasing torrentially, I would subject them to early enteral feeding as early as 2 days. And the reason I think we've adequately discussed both in the previous question and in Dr. Alisha's talk.
Absolutely, Abhishek. Thanks for saying that and reiterating everything that was discussed. But it's very important that we start enteral feeding early, 2 days probably, within 2 days. And you may start with trophic feeds in patients who are unstable. And then you might have to keep going up and up on that to meet your targets. And if by 5th or 7th day you don't meet 60% of your target as prescribed by Neel already, then we might have to think separately and out of the box. Yeah, the next question to Dr. Hariprasad, what is the concept of nitrogen balance?
So that's a very, divulging a little into the biochemistry or the physiology part. So nitrogen, in my opinion, is taken as a surrogate for protein. So we know in ICU, you have a lot of things going on. Patients are in sepsis, they're in a catabolic state, the muscles are being lost, and so on and so on. But to put it simply, if it is a positive nitrogen balance, that just means that the patient is getting more of nitrogen in rather than the nitrogen going out. So that would mean two things. The more nitrogen is coming inside than what is going outside, which means there is more of anabolism. That is, your muscles are formed, or your other organs are formed, and so on. So we all try to keep the patient in a net positive nitrogen balance, where we want the patient to go into anabolism and not lose the muscles, which we are very afraid of, which leads to certain other things later on. So early in the phase of sepsis, you have a net nitrogen negative balance where the patient is losing nitrogen. And then we try to strive it and bring it to a net positive balance where the nitrogen is coming inside. There is no more catabolism happening and the patient is not losing the muscle. So that's the whole concept of nitrogen balance. So positive, great for the patient. Negative, early phase, it may be physiological. But then later on, we must make sure that we are not leaving the patient in a net nitrogen balance.
Thanks, Dr. Hari. Very rightly said. I'll just add a couple of points. 1 gram of nitrogen is equal to 6.25 grams of proteins. So when we talk of nitrogen, say 90 grams of proteins, again, as per the prescription Neel made, it would come to about 15 grams of nitrogen. Unfortunately, a critical care patient who's sick loses 15 to 20 grams of nitrogen per day in the urine. So to match that is almost impossible, but we need to know the figure. And sometimes when we feel that the nutrition is not adequate, then we may want to do a nitrogen balance and actually calculate it. So you can do a 24-hour nitrogen. You can take it from the urea. You can add 3 to 4 grams of additional loss from other spaces. And then you can try to keep a positive nitrogen balance. So in some cases, you might want to actually do that. Next question to Neel. We'll go in an order. No, sorry, to Alisha. A 75-year-old COPD patient on mechanical ventilation has lost 6 kgs over 3 months before coming to the hospital. How do you assess the nutritional risk and elaborate on a few scores risk?
So already in the question, I think it's mentioned it's an elderly COPD, somebody on the ventilator. So obviously respiratory muscles are quite unused, 6 kg weight loss. That itself is showing a high inflammatory burden. And as we already discussed that, yes, we have we have many options for scores. Most commonly, subjective global assessment is being used, but I think Nutrix score is easier. Those 5 parameters we look at. And if you have IL-6 levels, then modified Nutrix score. But the standard is right now Nutrix score. NRS subjective global assessment as being still used, but I would still prefer Nutrix score. And then the MUST score also, which has come up. So once you screen with a Nutrix score and know whether your patient is at a high risk or a low risk, because that is going to help you to prepare the prescription for nutrition for your patient. And then the upcoming score is the GLIM score, which actually grades your malnourishment, whether it's a mild, moderate, or severe. And then you can redefine your targets accordingly. So this patient is definitely with a higher inflammatory burden, high catabolic. So accordingly, target calories have to be given with the protein requirements as Dr. Neel had mentioned.
Absolutely. So there are many scoring systems. You need to follow one. The reason is that means you're paying enough attention to the nutrition also of the patient. It doesn't matter which score you use. GLIM score is more for understanding the malnutrition status, even if they've lost about 5% of their ideal body weight in the last 1 month, or if they have not been eating for the last 1 month, it just directly puts them at high risk. So this is the high risk patient where we need to take nutrition even more aggressively in the treatment. And remember that it should be started from day 1 or day 2. Next question to Neel. A patient with severe pneumonia has a high CRP and low albumin. Does albumin indicate malnutrition?
So, sir, again, this will depend on where the number one for sick patients. We're talking about critical patients. A patient has come in with severe pneumonia. So, in such cases, the single line answer would be that albumin is not a marker of nutritional status in critically ill patients.
Absolutely.
It is normally if a patient you are seeing on an outpatient basis, and again, not a single value, you look at a serial values, but in ICU patient, it marks inflammation. The more the inflammation, the more the capillary leak. It is basically like CRP is an acute phase positive reactant, albumin is a negative phase reactant. So with severe infection, with more interleukins, with more capillary leak, there is more albumin redistribution in the capillaries and gradually the serum albumin goes down. So in such cases, we should not take it a marker of nutrition. It is of disease severity, prognosis, mortality risk in some particular cases, even the length of ICU stay. But as per whatever trials that we have, number one, we don't have randomized control trials for just testing albumin for as a nutritional parameter in the ICU. We have secondary analysis, we have cohorts, we have a lot of systemic reviews which have been done. But what even the international SPEN guidelines recommend is that albumin should not be used as a marker for the critically ill patients, and it can represent as a marker of inflammation, but in a baseline state. Now, if a patient is non-critically ill, come to you as an outpatient setting with the clinical. In the last case, you discussed a COPD patient with significant muscle wasting, weight loss. In the outpatient setting, you can still correlate and try to use it as a with your clinical history, but definitely not in a critically ill patient.
Absolutely rightly said. So albumin is actually having a half-life of 21 days. So if the patient comes in and then the albumin starts to drop, it will take 3 weeks, which we have lost the boat. Secondly, albumin is only a marker that the previous nutrition status was okay or not. And as you rightly said, inflammation, cytokines, capillary leak causes it. So that's perfectly said. And then they came up with other markers like pre-albumin and transferrin, but none of them have seen the light of the day. So albumin low does not mean that the patient's nutritional status is low. Next question to Aneesa. Aneesa, when would you replace oral albumin in a critically ill patient? Many formulas are available now, and would you be giving oral albumin to patients that come to the ICU?
That's a
I'm
tricky
not talking
question.
of IV albumin given for hepatorenal syndrome or sometimes in sepsis. I'm talking of oral albumin as a nutrition.
It's a tricky question, sir, because to the best of my knowledge, availability of an oral albumin supplement has not been there. And because it gets digested in the GI tract as a protein. So in critically ill patients, IV replacement is possible with 5% or 20 to 25%, and not oral. And we have specific indications for IV albumin replacement when a patient has low levels, after a large volume paracentesis, patient may lose 6 to 8 grams of albumin after the ascitic tab. Or if a patient with SBP, that is spontaneous bacterial peritonitis, to reduce the risk of hepatorenal syndrome, we need to replace albumin. And if you have patient with hepatorenal syndrome or a septic shock requiring large volume resuscitation, there is some role for using albumin infusion.
Yeah, thanks. Yeah, it is available. Now, oral albumin is available since almost a year and a half, and there are many companies which provide it. You rightly said that there is no data to say that you should be using it. But many a times the problem with high protein is the gut tolerability. They would have diarrhea, etc. So when you give albumin in its form, it probably can be digested in a little better way. So there may be a role, especially in patients who have not reached the ICU, but are transplant patients, are oncological patients. They have a CA chest, etc., a lung, etc., and they are planned for a surgery 2 weeks, 3 weeks later. Their nutrition has to be pepped up, and that will reduce the frailty index, and therefore it may have a role. So very rightly said. Abhishek, how does overfeeding affect pulmonary patients? So why not err on the side of overfeeding? So I will write 30 calories so that, at least 20 will go in. But suppose 30 goes in and you have a wonderful ICU and you are very strict as a intensivist and a pulmonologist, then what are the harms of overfeeding?
So Dr. Alisha in her talk retaliated, and I agree with her that she is more comfortable underfeeding the patients than overfeeding. So overfeeding not only leads to hyperglycemia and an increased risk of infection, hepatic steatosis and hypertriglyceridemia, but also in respiratory patients, giving more carbohydrates leads to more CO2 production. So I'm not very comfortable with that, but because it then leads to this conundrum of prolonged ventilation, difficulty in weaning, increase ICU stay, morbidity and mortality eventually. So I would target somewhere around 25 kilocalories per kg per day rather than going aggressively. And if the patient is tolerating the feed and I feel that the patient is being adequately fed, I would eventually titrate the feed, but I would be more comfortable a little underfeeding. my patients.
Absolutely right. Absolutely right. And we tend to overfeed the obese patients because we feel they need more. But as rightly said by all of you all, we need to not, we have to have normal calories or even hypocalories, but proteins are more important than how much calories they get. So, in my view, I would even be okay with 20 calories, but I would need per kg per day, if not 25, but definitely err on the side between 15 and 25 and not more than that. Sorry, Dr. Hariprasad, I'm asking you all biochemical and questions, but I'll come to the practical ones also. What is the respiratory quotient and how does it indicate that we are overfeeding? To continue
Yes.
on the same answer of Dr. Abhishek.
Yeah. So again, it's a biochemistry question there.
Can't be heard. Dr. Hari, some network issue. Uh, we can't hear you, Dr. Hari Prasad.
In
No, Hari. Can others hear him?
simple
No.
I think there is a problem of network in his.
Yeah, yeah.
terms,
Dr. Hari, should we come back to you and we will address the respiratory quotient a little later? Alisha, how do you tailor the feeds or the nutrition in patients of COPD, ARDS, anything in particular that you would want to do? You already mentioned it in the talk, but just for everyone's.
So just a little continuation from what Dr. Abhishek mentioned and you also spoke. So if you have indirect colorimetry, then isocaloric is feasible. If you don't, then hypocaloric or permissive underfeeding is better in these patients. You don't load them with calories, but you give proteins because you want to preserve the lean body mass, and also in the acute phase, catabolic phase, proteins are important. There is no particular, confirmed role that you need to give the specialty formulas with very low carbohydrate and high fat. It may be individualized if depending on the patient, but as such, no clear rule. And the other, otherwise, we feed these patients as any other regular patient. And certain things to be remembered in COPD patients, I'm sorry, in ARDS patients would be not to stop any feeding once you have probed the patient or you're paralyzed.
Very rightly said. Dr. Hari, are you back with us? Dr. Hari, can we? Otherwise, I'll answer the question of respiratory quotient a little later. Can someone check Dr. Hari's network, please? Yeah. Okay, the next question is to Neel again. What causes feeding intolerance in the ICU? So we may write a high prescription. You've already given 25 kilocalories. You've said 80 grams of proteins for your 60 kg person. But then feeding is not tolerated. So the next day, the nurse and the intensivist come and tell you a patient is not tolerating the feeds that you have written. So what would you do? And why does this happen?
So, sir, if such a case comes, then we have to troubleshoot. So, in this case, either the patient will have increased gastric residual, the aspirate will be on the higher side, or the patient will have abdominal distension, vomiting. Then, in such cases, or a ileus, or in some way we know that the feeds are not getting tolerated. And either it can be some patient-related factors. Is the patient on ventilation? Is he on high PEEP? Is he in a prone position? Are the sugars too high? Is there any electrolyte imbalance, like a patient has a low potassium, low magnesium, low phosphates? Is there any other GI illness that the patient has? Is there any small bowel dysmotility? Most common in the ICU, sepsis itself can cause feeding intolerance. Is the patient on any drugs? We look at, is there any sedatives? Is there any neuromuscular blockers? Any anticholinergics that the patient is on? And is also inotropes. If a patient is on too many inotropes, and in cases you're even suspecting there is any mesenteric hypoperfusion, then in such cases, even all these can cause a reduced motility of the bowel, which can lead to a feeding intolerance. So in such cases, you correct the reversible causes like electrolytes, the drugs that are likely to cause you stop, tighter sugar control, optimize the sedation. Try to continue enteral. Still, you should try to continue the enteral nutrition whenever feasible. And one or two increased RT aspirate should not be the basis of your decision. Ideally, if the gastric residual volume for almost 2 to 3 feeds is more than 500 ml, that is when you'll think that this patient may be facing feeding intolerance. You can use prokinetic agents. and still try to resume feeding within a short period of 24 to 48 hours. So these are some things that we should keep in mind whenever we think about feeding intolerance.
You've beautifully enlisted the causes and how to troubleshoot them. Just one word as described in the lecture. The GRV is now not supposed to be checked, but I completely agree with you. We still check it. What used to happen is the GRV, if it was high, the feeds were not given. And that's why they have removed it from the algorithm. But I think if you check the GRV and are troubleshooting it in the proper way, as you mentioned, then it is a good tool yet.
So
The
in
next,
your, like, just my question is, in a
yes.
real-time ICU case, like if a patient is having, like, the nursing staff will definitely tell you, right, if the RT
Yeah.
aspirate is
Yes.
significantly
Yeah.
high. So
So they are still
practically, do you
matching.
still use it that way in
Yeah.
your?
So they are still practically using it because the nursing will not be allowed not to check the GRV. So they will have to come back to us with a GRV and they will keep asking us, can we give it? So more often than not, we say that we should use it unless it's a obvious, like because the RT feed, it's not a vomitus, but they will have a very high aspirate in one go. Then obviously we'll stay for 2 to 4 hours and then start a trophic feed.
So
This
in case
happens when you have
we
overdone the prescription. Yes, Alisha.
In case if we, what we can suggest is in the ICU is that if despite telling it's very difficult to sometimes make the nursing understand that you should not be checking GRV, rather what we can tell them is if it's something less than 200 to 300, push it back. Don't try to withdraw it and discard the whole feed. That's what they do and they start on IV fluid. So that should not be done. Push the feedback would be a better option and inform the doctor on duty.
Yeah. Another very, very important point that I noticed from your statement is patient is NBM, so we give them IV fluids. It is, I request everyone here and whoever is listening, not to supplement IV fluids as a marker for not giving them feeds. It's absolutely okay not to give fluids, even in the patient who's NBM, if the patient does not need the fluids. So fluids is not a replacement. We invariably write 60 ml of NS or RL to be started because patient is NBM. That is absolutely ridiculous. Dr. Hari, is your network okay? Can you answer the question on respiratory quotient?
Yeah, I think the,
Yeah.
the, the
Yeah.
question was quite biochemical that the network itself didn't like it.
The wiring went wrong. Okay. Sorry, Hari, for
Yeah.
those two questions back to back to you, but we will
No
definitely
issues. No.
compensate with some clinical ones soon. Yeah. Tell us.
Yeah. So hope I am audible now.
Yes, yes. Please go ahead.
So, what I was trying to tell is that respiratory coefficient or respiratory RQ, what we say, is a measure of the efficiency of the fuel that goes into our body. So, for example, if you have glucose, which has an equal number of carbon dioxide and equal number of oxygen molecules, you burn it, you have an RQ of 1. So, that is 6 divided by 6. So, how we calculate is the carbon dioxide which is produced divided by the oxygen which is consumed in that. Now, fats normally has less of oxygen. So that's why you end up with a low respiratory coefficient or RQ of less than, around 0.7. And everything else comes in between 1 for the carbohydrates and 0.7 for the fats. So why it is important is sometimes if you are going into overfeeding the patient, like we were discussing in between, some of these carbohydrates may causes it will increase the respiratory coefficient RQ above 1. So there's certain other issues with the COPD patients where, there has been in the past some stress on giving them high fat feeds and all that. But it's all related to how much carbon dioxide is produced and how much oxygen is actually needed to burn that fuel. So just to understand the carbohydrates, 1, fats 0.7 and everything in between that.
Yeah, thank you so much. That's very nicely explained. But we just wanted a little basics also to be understood. And that's why this question. But you need a metabolic cart or an indirect calorimetry to actually know the carbon dioxide consumption and the oxygen consumption, carbon dioxide and oxygen balance. Next question to Aneesha. Is there a role for formulated, ready to give peptide-based formulae available, which are there in the market? Sorry, again, a question which you can answer very quickly or refute it, whatever.
though peptide-based formula are not routinely recommended for all ICU patients, they have two advantages, that they are easily digestible and they are better absorbed. So we have definitely a subset of patients with these problems where we need to use peptide-based formulas, like as Dr. Alisha had already presented in her very detailed presentation. Patients with severe acute pancreatitis requiring enteral nutrition, patients with prolonged ileus who have recovered bowel function, but they demonstrate poor feed tolerance. In such patients, we have to consider. Similarly, if we have patients with significant intestinal mucosal injury and also critically ill patients with persistent feeding intolerance through the enteral route, these are the patients who might benefit with peptide-based formula.
Yeah, excellent. So we have polymeric and oligomeric, and these are elemental diets and they are easily absorbed. And many a times it's easy to write these products by the nutritionist into our ICU, and we say 2 scoops twice a day or every 2 hourly, and then the calories can be counted. But mind you, the scoops of different companies are different, and therefore never write scoops. You always need to write the amount of calories or the amount of ml or milligrams given. Next question to Abhishek. A ventilated COPD patient has received less than 50% of protein requirements. So we've written 25, but we've got very little for 10 days. What complications of underfeeding?
The major complication here would be a loss of muscle mass, which would again initiate the conundrum of prolonged mechanical ventilation, difficulty in weaning, etc. Apart from that, a decrease in the protein intake can also lead to complications such as poor wound healing or an impaired immune function, leading to an increased risk of infection. So always target somewhere around 1.5 to 2 grams per kg per day. And in certain cases like severe burns or trauma, we can also go up till 2.5 grams per kg per day. So this is what is recommended and this is what we should try and target.
Thank you so much. Yeah. Dr. Hari, now a very clinical question. A severely malnourished patient who now develops hypophosphatemia, hypokalemia, fluid overload 48 hours after starting his feeds. So what is your diagnosis and how will you manage?
Yeah, so this classic, the classic presentation of your refeeding syndrome, as we all would have seen in theory. I've seen very few cases actually in practice, because nowadays the ICUs are so well that hardly we see any refeeding syndrome. But to put it in a simple way, when patients are starving, you have a catabolic state. Your cells are being catabolized, and the insulin is at an all-time low. You have glucagon and other hormones being high. Now, suddenly you start feeding this patient. What happens is that the insulin starts spiking and all the other opposing hormones suddenly go down. And now cells believe that, okay, now there is enough glucose. We should start, constructing or mobilizing the stools for anabolism. So, and one of the first things that cells do is make more of genetic material, the DNAs and other things, and which requires phosphate. So suddenly what happens, the cells absorb these elements from your blood, that is the phosphate, the magnesium, the potassium. If you remember, all of these are required for anabolism or making the genetic components and all that. So suddenly your serum levels of phosphate, magnesium, everything starts falling down. So this is the classical refeeding syndrome, so where you see the hypophosphatemia along with hypokalemia, then you have the fluid imbalances which occur. So the most important caveat is to prevent it. So if somebody has been starving, or when you start nutrition, you start slow and then give time for the body to kind of, accommodate those extra calories which are coming in. And over the span of maybe a week or 10 days, you increase the caloric requirement so that you don't have this sudden fall in the electrolytes. So classical case of refeeding, but I don't know, I've seen very few. Nowadays.
Absolutely. So absolutely well put, and we can give them thiamine, and we can look at replace the potassium and the phosphorus also. Now we have available phosphorus supplements. A classic example in light vein is a senior consultant is on leave, patient admitted under him or her, and 3 days later when he comes in, he realizes that, oh, my patient is not being fed. So he writes 30 kilocalories and starts feeding, and to make up for the 3 days that he was overfeeding himself or herself. Anyways, Alisha, the next question to you. What is the indication? When do you say enteral nutrition enough is not enough, and you move on to parenteral.
So as we have discussed, so based on your nutritional risk assessment, you decide it's a low risk or high risk. In low risk cases, we wait, but in high risk cases, suppose the patient has bowel obstruction or ischemia, or there's a high output fistula, very severe cases of paralytic ileus, because in mild cases, you are still justified in giving enteral nutrition. So all in these indications, you prefer starting a parenteral nutrition, where you know it's a high risk case, but you cannot give enteral nutrition, the targets cannot be met, you start with parenteral nutrition. In other cases of low risk, where you have started with enteral nutrition, but after 3 to 4 days, you are realizing that your targets are not met, at least like what we discussed in that nutritional hour, 60 to 70% of the target needs are not met. And then as a to cover the deficit, you add parenteral nutrition. So these will be the indications.
Absolutely, yeah. So many a times when you are not meeting the targets of 60% by 5 days of your target aim that you have written, you may supplement parenteral nutrition to the enteral and not always switch from enteral to parenteral. So you need not give total parenteral, but sometimes you may supplement the calories and the proteins by supplemental parenteral nutrition to the non-tolerant or non-achievable targets of enteral nutrition. So very rightly said. Next, to Neel, can you elaborate on the role of immunonutrition in pulmonary patients, especially the glutamine, arginine, omega-3, vitamins, minerals, very, very quickly? Yes, Neel. Neel, it's for you.
So, sir,
Neel? Yeah.
sir, all of these, they are... Hello?
Yes, yes. Go ahead.
Hello? Yeah.
Yeah, we
So,
can
sir,
hear you.
what all these normally in practice, what happens is that glutamine, if I talk about individually, glutamine does not benefit, and it has a risk of potential harm. So if especially in ICU, if a patient has multi-organ failure or is critically ill, in such cases, it has a negative effect. So rather than helping, it can harm the patients from whatever evidence which is currently based. Arginine does help in especially perioperatively in oncosurgery patients. If there is a patient with elective surgery post-operatively, there are studies and trials which tell you that arginine does help. Omega-3 fatty acids in some older literature or ARDS studies was said that it does help in the oxygenation, but there is no recommendation. So not positive, not negative as per the ASPEN guidelines. Vitamin D, definitely if there is deficiency, we should correct, but with deficiency, not routine practice. Vitamin, even zinc, selenium, and vitamin C, whatever other micronutrients are there, if there is a deficiency, then you definitely correct. But there is no convincing study that as an additive, despite having no deficiency, giving it will give you any additional benefit. And what the only to be supplemented in cases of deficiency in such cases.
Yeah, perfectly said, Neel. Thanks. Aneesa, a patient receives
So we
adequate
should not be
calories.
using a cocktail of
Oh, sorry.
supplements in a critical.
Yeah. I completely agree. Yes, Neel, thank you. So we should use it only in the specific group of patients where we might want to use it. Omega-3 was used in ARDS as per few studies, but again now specialized nutrition and immunonutrition has taken a back seat. Aneesha, a patient receives adequate calories, whatever we've written they've received, but still is profoundly weak. When you try to mobilize them, they cannot even stand up, or they can't move their hands and legs equally or properly in bed. So what could be the reason?
So, sir, at this point, I would like to enlighten our audience about the all other causes of weaknesses. Like as we all know, it's a hypercatabolic state. There's a cytokine storm and increased level of stress hormones where the muscle protein breakdown exceeds the protein synthesis. Then there may be inadequate protein delivery, but there could also be anabolic resistance where despite adequate nutrition, the muscle protein synthesis is blunted. The amino acids due to the skeletal muscles become less responsive to the amino acids and insulin during critical illness. There could be component of ICU acquired polyneuropathy and myopathy because patients might be on polypharmacy. They might have received prolonged mechanical ventilation, corticosteroids, and neuromuscular blockers, and these all could contribute to this development of critical illness neuromyopathy. Then other contributing factors could be deficiency of micronutrients like thiamine, vitamin D, magnesium, phosphate, and also prolonged bed rest, there will be rapid muscle atrophy. So that leads us to the fact that early mobilization is also equally important in addition to nutrition and rehabilitation.
Very, very precisely said. Thanks, Aneesa. So there can be weakness. There is something called as anabolic resistance, and you touched upon everything. Abhishek, which pulmonary ICU patients are particularly vulnerable to nutrition-related complications, and why would that be so?
Sir, I would say that any patient in the ICU is vulnerable to nutrition-related complications, but categorically COPD patients, because of an increased risk of breathing and chronic cachexia, ARDS patients, because of the markedly increased inflammatory response that they have and the severe hypercatabolism that they face. Any patient with severe sepsis because of accelerated protein breakdown, and categorically patients who are elderly and frail because of the sarcopenia that they have are particularly at an increased risk of ICU-related nutrition-related complications.
That's absolutely true, Abhishek. So any patient and every patient is at risk, and the prolonged ventilation, difficulty in weaning would be the ones which would definitely need extra attention. Dr. Hariprasad, what is ICU-associated weakness, and is there a way of differentiating it from critical care neuropathy? All the tough questions are coming to you, Dr. Hari. Yeah.
Yeah, so again, a vast topic. I think I'll just touch
Yeah.
upon the basics of that. So, as we all know, the longer a patient stays in the ICU or say any kind of critical illness or for that matter, ventilator, they eventually will go on to develop some kind of weakness there. And now it is imperative that we distinguish it between what is causing it. Is it due to drugs? Is it due to some paralytics which we are using or even some antibiotics? Or is it something a more sinister one, which is the critical illness related myopathy and the critical illness related polyneuropathy? So these two terms are very, very important there. And sometimes we do see a mix of both of these. So in broad terms, the critical illness polyneuropathy usually affects your distal muscles, where you have a distal motor and sensory loss, which you can easily confirm on a nerve conduction study, as opposed to critical illness myopathy, which usually affects the proximal muscles, where the nerves are pretty much intact, but you have a loss of the proximal muscles. Now, both of these are important because one, it will impair your weaning potential. That makes it difficult for the patients to get out of the ventilator. Second, the post-ICU care, the once the patient comes out of the ventilator or the ICU, they are left with a lot of weakness, as well as the sensory and the other losses, which will take a long rehabilitation and those kind of things there. And there are certain predefined, we know that certain risk factors are there, which we can somehow try to avoid or mitigate these factors so that we don't end up with these situations. For example, hyperglycemia is a very known cause for both of these conditions. The longer stay in the ICUs and they are known to cause these illnesses there. So by mitigating some of this, we
go ahead, please.
Can at least reduce the incidence of these, but it is very important on the lookout for them. Once then, kind of offering them the rehabilitation and the physiotherapy.
So because of so much catabolism that the patient undergoes, and maybe we fall back on the nutrition, especially the proteins, and not bothered about their physiotherapy, we actually land up and we realize an ICU-associated weakness, which is a father term for CIP and CIM. We realize it too late, and you rightly pointed out that we should be aware of it right from the beginning and try to prevent it rather than anything else. So, Alisha, why is ICU-associated weakness a very major concern? And besides nutrition, what all can you do? Just very quickly. Yeah.
Obviously, because if the patient has an ICU-acquired weakness, then your length of stay increases, it's difficult weaning, so ventilator dependence increases, increased risk of infections, and again, poor quality of life. And what you should do to avoid it are I think all the panelists have enlisted: early mobilization, rehab, good nutrition, good glycemic control your sepsis well, and obviously be very careful with your neuromuscular blockades and steroids.
Absolutely. I was told we have 100 more questions to answer, so we'll quickly go over the last round. Dr. Neel, a patient with severe ARDS remains difficult to wean despite improving lung compliance. So his COPD is better, his ILD is okay, but has nutrition got to play a role in a difficult to wean patient? Neel?
So I'll just tell that we should ideally try to, I give a simple acronym here that if you breathe, right, you want a patient to come out. So you can use a acronym in such cases. So B is for you build muscle. So in such cases, a protein of 1.3 gram per kg per day. So the patient is receiving less protein, you increase the protein. Second is that will improve the muscle weakness. Second use R is for replacing all the deficiencies. So calcium, magnesium, phosphorus, vitamin D, whatever is nutritionally deficit. Hypophosphatemia can aggravate muscle weakness. So you replace the deficiencies. E is for early enteral. So we discussed early enteral nutrition start within 24 to 48 hours. Avoid overfeeding. Why? Because overfeeding will cause more carbohydrate, more carbon dioxide, more ventilatory demand, and again, respiratory failure will worsen. T is for training muscles. You use your physiotherapist, make sure patient has inspiratory muscle training. You halt anabolic resistance. So if the patient has very high sugars, you make sure you have a tight glycemic control between 140 to 180, and you evaluate other causes of ICU related weakness, which we have already discussed. So breathe is an acronym which can help build muscle, replace deficiencies, early enteral nutrition, avoid overfeeding, train the muscles, halt anabolic resistance, and evaluate for other ICU related causes for ICU related myopathy.
Neil, I've fallen in love with this acronym. It is an amazing way to answer this question. And as I said, you all are also learned that I'm really learning at every stage with every answer. Very, very nicely put. Dr. Aneesa, what is the role of POCUS? We use it a lot in critical care and pulmonology, look at B lines, etc. But does it have a role in assessing the nutritional status of the ICU patient?
Looking at the muscle mass has become a very fascinating point in nutritional assessment. We look at the rectus femoris muscle and quadriceps cross-sectional area. On the day 24 to 48 hours of admission, we do it at the baseline and we monitor it. So how will it help us assess the muscle wasting? We'll look whether there is a significant cross-sectional area loss. So as Madam had already described, there will be a 10 to 30% reduction in the CSA loss can be significant by day 7 or day 10. As also the rate of loss correlates with the duration of mechanical ventilation, the length of ICU stay, and also functional outcomes. We also look at the echogenicity of the grayscale analysis of the muscle. Fatty infiltration or edema is a marker of poor muscle quality decline. So,
yeah. So very rightly said, the quadriceps and the rectus femoris is the muscle to see. Just one more point on that. When we are weaning, we can even look at the diaphragmatic excursion and the thickness of the diaphragm. So it is a a compendium of the entire thing where we can use POCUS. We can also use it for weaning. We can also look at the nutritional status, as rightly said. Abhishek, is there a correlation between nutrition, frailty, and the critically ill pulmonary or any other patient? Because frailty is something which we don't really look into unless patient is for a transplant or patient is geriatric. So is frailty important, and what is the correlation between nutrition and frailty?
So absolutely, sir. So frailty is a state of reduced physiological reserve, and that strongly influences outcomes in critically ill pulmonary patients. So if you look at the relation, chronic poor nutrition would make a patient sarcopenic, prolonged sarcopenia will make a patient frail, and frailty eventually leads to poor ICU outcomes. And a critically ill patient here further accelerates this process through increased inflammation and protein catabolism. So yeah, frailty does play a very important role as far as ICU outcomes are concerned.
Sure. Thanks. So, Dr. Hariprasad, the patient is ready for ICU discharge. But still sarcopenic, and would you continue feeds, or you would say that you eat what you like, ghar ka khana khao, and send the patient out of the ICU or the hospital?
Yes, so if the patient is sarcopenic and I have reasonable doubt to suspect that, we need to increase his muscle mass, then I would not probably send him directly. I'd rather put him through at least some kind of functional assessment, either using the scores or even our, quick assessment, hand grip exercise, strength and other things. And then look at his nutrition. If he has been malnourished or his functional scores are poor, then probably put him through a proper nutritional support, which should definitely include a good high protein diet, something targeting 1.5 to 2 grams per kilogram per day. Also looking at his calorie requirements, matching the calorie requirements, and also not forgetting the micronutrients part, which I sometimes see is overlooked often. And then put him through a proper rehab so that they don't go to ward and then come back again back to the ICU. So get the physio involved, put them through a mobilization, strength training, offer them some kind of an occupational or a rehabilitation program. So their trajectory should be from ICU to ward to the home rather than come back again to the ICU.
Perfect.
And then always offer them a follow-up after a couple of weeks. That's very important.
Yeah. And here there may be a role for the pre-mixed ready formulas, because they can have their own food and then supplement it with something else to meet the aims and demands. And rightly said, we need a whole multifactorial kind of approach where there is physiotherapy, increased quality of life, and the patient actually has become a survivor and is doing well. Alisha, the last question for the panelists, then we take the questions from the chat box. What do you see as the future direction of ICU nutrition?
So we are in that era of one size doesn't fit all anymore. So precision nutrition is the way forward. As we discussed that, we talked about micronutrients, we talked about all the special formulas. We are not saying no, no, no at all. Though not recommended in guidelines, we may consider. So I think that is what precision or personalized nutrition is. AI has come into use. So you have this continuous data collection, metabolic data collection, and that can give us a real-time estimation of what our patient wants. And especially, I think the most focus should be on the post-intensive care syndrome, like what Dr. Hari said. Once the patient goes out, how do you manage their nutrition? Focus on that. Like whatever you took care in the ICU, the post-op recovery and the rehab phase should also be well taken care of.
I thank all the panelists for enlightening me and everyone here. And it's still not over. Abhi to trailer, pura picture baki hai. Let's take the questions quickly. I'm sure many of these have been already answered. So let's pick up on some questions. Should I be doing it? What's the format? I should be doing it, right? So there is a question: how is medical MRC sum score performed, and what is the diagnostic cutoff? So let me tell you that we do not, these forms and these scores are already ready, and you just need to attach it to your file, and you need to just tick box everyone for every patient. And it's not necessary that you follow any one score. We don't follow the MRC score. There is more of a other scores like Nutrix score and the NRS score and now the GLIM score. When should ICU associated weakness be suspected clinically? Anyone can answer. Huh? So we've already, Hari has beautifully answered that. What are the recommended calories and proteins? We've said that 20 kilocalories per kg to 30 kilocalories in some situations, and protein should be 1 to 2 grams, increased in cases of burns and maybe even in ARDS. What is the role for specific nutritional supplements? We've just answered it. And we said that maybe omega-3 in ARDS, but not others, unless there is a deficiency. Anyone else? I'm just trying to answer all these questions.
Trauma and burns patient, I think that subset, there may be a role of all these special
Yes.
extra nutrients and formulas.
And
And that
post-operative, I
MRC
think data said arginine for post-op patients.
Yes, you rightly said that, Neel. So arginine there, and only the specific group. Across the board, you definitely can't. Does tight glycemic control reduce this? So tight glycemic control is needed for ICU care, and it decreases the mortality, but directly it may not have a bearing on the associated weakness. All are from the same participant. Acha. What is anabolic resistance and why does it occur? I think Dr. Aneesa very rightly said that there is anabolic resistance happening. And do you want to take that answer, Aneesha? Quickly, just
Due
again.
to the effect of insulin and other stress hormones, the muscles are not able to use the amino acids and help in muscle protein synthesis. The muscle destruction is ongoing, but the synthesis is not happening due to the anabolic resistance. This is one cause of weakness in the ICU patients.
Absolutely. What is the gold standard of measuring energy expenditure, and should you have an indirect calorimetry? Dr. Prasad beautifully answered that. Indirect calorimetry is not available is available only in less than 5% or 2% of the ICUs, and I have never even seen it except when I went to Boston. And calculating the basal energy expenditure by Benedict equation is not always feasible. So as again Dr. Hari mentioned, the nitrogen balance needs to be seen, and presume that a patient who is critically ill is losing about 16 to 20 grams of nitrogen, which is equal to 100 to 120 grams of protein. So you are multiplied by 6. So you need to at least meet, if not a positive balance, at least meet it somewhere down the line. Is permissive underfeeding beneficial during the acute phase? So as we said, trophic feeds need to be given and started. Gut has to be used, otherwise the enterocytes and the gut microbiota will be at a loss. And I personally feel acute phase and recovery phase don't need to be differentiated. If the patient tolerates the feeds, keep going up on it. Alisha, you can take the next few questions. Which biomarkers best reflect muscle
So as
wasting?
such, known biomarkers only I think available right now is creatine kinase. There are a lot in still in papers, but I don't think it has been validated, at least a particular biomarker which can be used. But creatine kinase, yes, definitely
Yeah,
there's a
yeah,
scope of using
yeah.
it.
Jay has asked role of musculoskeletal physiotherapy in an unconscious patient. So yes, we start physiotherapy from day 2 or maybe even day 1 if the patient is stabilized. And we definitely start the physiotherapy in bed, initially passive, and then once the patient is conscious, then we even keep a cycle on the bed, a stationary cycle, and we try to make them move their hands and legs. So that's necessary. In an unconscious patient, obviously, only passive movements will be done to prevent any foot drop or any other problems. Sharbari has asked, could you discuss the major risk factors associated? We've discussed that already. How should rehabilitation continue after ICU discharge? Dr. Hariprasad has beautifully mentioned that. Is it okay if I keep moving because these questions have been
Yeah.
answered? Yeah. Can neuromuscular electric stimulation substitute active rehabilitation? Very, very interesting question, Sanket. So basically, nothing can replace a good active mobilization and physiotherapy. But when the diaphragm has weakened and the diaphragm thickness is less, many a times there are some electrical stimulations given to the diaphragm to help the patient breathe better and to wean them off. So it has been tried, especially in spinal cord injury where the diaphragms are extremely weak, along with NIV. How common is ICU associated? We've mentioned that 1 out of 4 patients will develop it, and therefore you need to be careful. Sharbari is again asking, critical care neuropathy, myopathy. Again, Hari has answered that. You need a nerve conduction to do that. And it really doesn't matter, is it neuropathy or myopathy or is it steroid induced? It is early identification and trying to give adequate nutrition, adequate proteins, rehabilitation, and early mobilization. When should enteral nutrition ideally be initiated? We said early. Everyone's heard the talk, but I think they want to hear it the second time. So within early enteral is the key. Within 48 hours. Does NMD use increase? Yes. Steroids and NMD usage versus the Abhishek. Now you can take it further.
Yeah.
I think only 2
So
questions left. Yeah.
yeah. So what are the currently accepted diagnostic criteria for ICU acquired weakness? I think Dr. Alisha has already enumerated it in her talk. Do you want to take it forward here, Dr. Alisha?
Yeah. Alisha or
Say it
Hari or
again.
anybody. Yeah.
The criteria would be the MRC, that is what the MRC scoring will be using over here. Anything less than 40, it signifies a severe ICU acquired weakness. And obviously the other clinical features you should be looking at, that diffuse generalized weakness, patient is unable to lift his limbs up, that we weak cough reflex, diaphragmatic weakness. And you should suspect all this in a patient who you're seeing has recovered from the pathology for which he was admitted in the ICU. and sepsis part is settled, the patient is hemodynamically stable, still your patient is not able to come out. And in these patients, your reflexes may be reduced, but your sensory sensations will be preserved. So in those cases, you should think of ICU-acquired weakness and use the MRC scoring. In cases where you can't use the MRC scoring, especially in sedated or non-cooperative patients, there NCS and EMG has a role. And so that's an ultrasound also can be, focus can also be used in those cases.
Absolutely. And the last question. Yeah.
So is there
Anyone
a
can
correlation
answer this?
between the duration of ICU stay and the risk of developing ICU-acquired weakness? I think Dr. Neel has already
That was
touched
the
upon
first
that.
slide of my talk, actually, that
10
study showed.
days. Yeah.
Yeah,
10
within
days,
10 days,
40%, 20 to 30%
20%
of
almost
loss.
loss of
I think
muscle.
that was also with Dr. Bajan's slide, 15 to 20% muscle mass.
Yeah, absolutely. I'm so grateful to the panelists here for enlightening us beautifully and the participation of everyone here with amazing online, what do you call it? So many online reviews and questions. And we've got more than 2,000 participants that have crossed this webinar, and I'm so pleased. If, with the permission of everyone, I can end here by a little 2 or 3 slides. Can I get permission for slide sharing? Yeah. So, are my slides seen?
Yes.
Yes.
Yeah. So just to summarize, how do I write my prescription for everyone's benefit? Assess the nutritional status, calculate the energy needs, determine the route of feeding always early, and we mentioned this 6 to 12 hours if hemodynamically stable. Estimate the protein requirement, and we must give maybe a positive nitrogen balance, so 1.5 to 2 grams per kg, and look at the gut integrity. Set the carbohydrates and the fat targets as well. You might want to give 55 to 60% of total calories as carbohydrates because they are the main energy source. And you might want to avoid them for hyperglycemia and maintain the sugars at 180. Fats should be less than 15% of the calories. Micronutrients and trace elements very cautiously as mentioned, and there are some levels here that you might want to fall back on. Choose your enteral formula if you are using any others. Immune enhancing does not have a role, but if the patient is intolerant and you can't switch over to a peptide-based formula. Monitor them and adjust daily. You may look at the GRV, but interpret it effectively. Electrolytes, renal function twice a day, glucose monitoring, maybe nitrogen balance. And when enteral feeding fails, indications for parenteral nutrition, which we have discussed. You may supplement the enteral with parenteral and not completely replace it. And special considerations may be used for ARDS and COPD. And then finally, as mentioned, personalize each prescription and monitor the dynamicity of the patient. So in summary, I've written a poem, and I'll just read out a poem. But before that, just 5 important points. Nutrition is essential for recovery, wound healing, muscle strength, reducing inflammation, improving immunity, and finally enhancing the quality of life. ICU-associated weakness is common, devastating, and is easily preventable if identified early. Obese patients are not necessarily nutritionally adequate. Gut is the motor of sepsis, and therefore you must use it early. Under and overfeeding have been proven to worsen the mortality and the length of stay. Critically ill pulmonary patients need nutrition and active mobilization early with physiotherapy for easy and early weaning and better outcomes. Frailty and nutrition have a bidirectional correlation. Is the chicken and egg literally so when we are talking about nutrition? The GI is also an organ, and thus nutrition often is life-saving. We pay a lot of attention to ventilatory strategies, urine output, renal replacement, vasopressors, but gut is also an organ, and it falls in the category of organ support. So in short, this is what we would do. And my terms here are, my statements here are, nutrition is my birthright and I will have it. And every patient in my ICU will have it. Nutrition is a prescription. Nutrition is a life-saving organ support system. So I've tried my best to write a small poem on this. I won't take more than 30 seconds. Hypermetabolism and calorie deficits are the hallmark of increased work of breathing, as it seems. The pulmonologist, intensivist, and dietitians have to work as teams. Hyperfeeding in ICU has become the norm and is often diabolic. Proactive and personalized nutrition prescriptions are indeed symbolic. Early and calculated enteral nutrition as a prescription should always be sought if the fight against ICU associated weakness has to be collectively fought. Newer strategies and AI could be some interesting experiments. High protein, adequate carbs, and judicious lipids often should be integrated with vitamins and trace elements. Precise fluid nutrition antibiotics in the management of pulmonary critical patient is key. An unending pursuit of excellence brings about in the eyes of the patient and the relatives ugly. So make survivors happen and not victims going out of your ICU. And thanks for healing by feeding. So I again thank the ICS. I thank my dear friend Amita, Dr. Rakesh, for hosting us. And I'm going to stop sharing these slides. And I had the most learned audience and the panelists here. And I've learned a lot about nutrition, though I thought that I knew a lot about it earlier, but I have learned lots, and especially your amazing breathe mnemonic, Neel. And I thank you all with my wholehearted thanks to the for having me over in this gathering. Thank you.
Thank you.
Thank you,
Thank you.
Khusrav Bajan sir, for excellent moderation, and you went through with great like all
Thanks, Neel.
topics covered, and especially the poem in the end was the like perfect that way.
I'm just trying this out. I think when you get old, you try all funny things. So,
Thank you.
anyways, this was an amazing discussion, and I think we have absolutely made use of the time perfectly.